Hello, everyone, and welcome to the ICD-10-CM Updates for 2019. We are so excited that you are with us today, and I'm going to introduce Joy Ewing in just a moment. But first, we do have a little bit of housekeeping that we want to make sure that everyone is ready for. First off, you'll see that you have the panel, the GoToMeeting panel on the right side of your screen. If it's in your way and you want to get rid of it, just click on the little orange area there with the arrow in it, and it'll move it over to the side. If you do want to ask questions, look toward the bottom part of that, and that's where you'll see questions as well as handouts, by the way. Your handouts are right there. So again, on that panel, go down just below questions. It says handouts, and then you can just click on the little arrow next to it and open it, and then click, and it'll open up your handouts. So the handouts are right there on that panel. If you do want to ask a question, just click on the question button and then type in the questions. Sharon and I will be monitoring those behind the scenes, and then if we have time during the presentation, we will get that information to Joy, and she will take those questions again as we have time to do that. Just as a reminder, you are in listen-only mode, so doing the questions is really the only way you can ask questions. Of course, we will give you more information at the end of the presentation today to talk to you more about your CEs. So Sharon will be with us then, so just hang with us there, and we'll be sure to tell you about how you get your CEs. I also wanted to remind you, we have a very interesting thing today because we want to make sure everybody stays awake. Joy's going to be fabulous, but remember that there is going to be that national alert, and it is at 1:18 Central Time, 2:18 Eastern Time, so everybody's phone's going to go off in the middle of this presentation. So I just wanted you guys to be aware of that, and we just did that on purpose, so you'll be awake and alert during the presentation today. So they say that it's going to be loud, just like an Amber Alert. So again, I just wanted to remind you all that that's going to be happening, and all the all the companies are taking part in that. So that should be a fun way to spend our day today. So let me just introduce to you Joy Ewing, excuse me. I've known her as Joy King for many years. Sorry, Joy. Joy Ewing is owner of Joy King Consulting, and she's a wonderful consultant, does a lot of audits, and is a great frequent contributor to us here at TrueCode, and we definitely appreciate her time and effort in helping us with these presentations. So Joy, I'm going to go ahead and turn it on over to you. Thanks so much.
Thank you, Karen, and welcome everyone this afternoon. As the title slide showed you, we are just going to be talking about the updates for ICD-10-CM, the diagnosis portion, which did go into effect on Monday, October 1st. And there are a whole lot of changes that came about this year that were housekeeping types of changes, like correcting misspelled words, changing and fixing extra spaces, and things like that. I'm not going to be addressing any of those today at all. I do believe that I've covered all of the new codes and deleted codes that are going to impact you going forward, but I'm not talking about any of those kind of cleanup issues. And obviously, this is the least amount of changes that we've had in ICD-10 for both CM and PCS since we implemented it, and it's kind of nice to have it sort of tapering off so that we don't have so many overwhelming changes to deal with every October. You can see on this slide a summary of the changes. There were 279 additions, and just for your information, only 7 of the new codes were MCCs and only 42 are CCs, so there's a whole lot of them that aren't either one. 51 deletions and 143 revisions. And in that little box there, I have not all of the 279, but most of the code changes I have sort of by category there, so that you can see sort of what body area most of the changes occurred. And you can see that about a third of the new codes that came out were related to the eye, the eyelid, and the eyebrow. So obviously the ophthalmology people were quite busy this past year trying to come up with things that they wanted to add into ICD-10. When I heard Nellie Leon Chazane in the AHIMA clinical coding meeting weekend before last, she said, who knew that the WITH guideline would end up being such a big deal and would require additional clarification every single year. But once again, they have added another little change that you see in bold there to that WITH guideline that we've been sort of grappling with over the last couple of years, just to clarify that that WITH guideline does apply both to WITH under a main term and also WITH under a subterm. So they want to make sure that there is no confusion about how to apply that with Guideline. Also, they retitled this guideline here, basically talking about documentation by clinicians other than the patient's provider. And they basically talk about that code assignment is based on documentation by a patient's provider, which includes a physician or other qualified healthcare practitioner that is legally accountable for establishing the patient's diagnosis. And then they go on to add another piece of a sentence there. There are a few exceptions, such as codes for BMI, the depth of non-pressure chronic ulcers, pressure ulcer stage, Coma Scale, the stroke scale, etc., that you can assign codes based on medical record documentation from clinicians who are not the patient's provider in these situations, since that documentation typically is documented by non-clinicians who are also involved in the care, such as the dietary people, the wound care nurses, etc. However, reminder at the very last sentence or two of that guideline that you still have to have the associated diagnosis that goes with those things, the BMI and the stroke, etc., documented by the provider. So it's not okay to code a BMI or a Glasgow Coma Scale or a stroke scale or the depth of a chronic ulcer or the stage without having that diagnosis documented by the physician first. They also have a totally new guideline this year called Social Determinants, and it's talking about social determinants of health, such as information found in categories Z55 to Z65, which does include the BMI, Coma Scale, stroke scale that we were just talking about. And it's related to things that are health hazards based on socioeconomic and psychosocial circumstances, that in those situations, code assignment can be based on the medical record documentation from clinicians that are involved in the care of the patient who are not the patient's provider, because again, that information represents social information rather than medical diagnoses. And just a little word about this particular issue, because we are moving more and more into reimbursement based on risk adjustment, these socioeconomic factors sometimes can play a huge role in risk adjusting these patients in terms of factors that are having a big impact on their health. So I think it's important when you find these things documented in the record to try to capture that whenever possible, because I think it does paint a better and better picture of the complexity of that patient's condition, what kind of chronic conditions they have, and what kind of socioeconomic factors might be impacting them. We also have a couple of guidelines here based on hurricane aftermath coding, and unfortunately, probably the people in North Carolina and South Carolina may have to be paying close attention to these guidelines because of what they've just been through recently. It's basically talking about using those external cause of morbidity codes to identify the cause of the injuries that are directly related to the hurricane. I think they found when we had the major hurricanes last year, especially Puerto Rico, that they had a difficult time trying to figure out what was directly related to the hurricane. And I think even the confusion that's out in the news about how many deaths occurred in Puerto Rico probably relates somewhat to some of the issues that they're trying to address with this guideline. I'm not going to read the whole guideline there to you, but I'm just going to, make you aware of that. So if and when you ever have to deal with this type of coding, you will be aware that it's there to guide you. Again, another page talking about the same thing as well. And then another guideline related to external cause codes that's brand new. All of these are in bold, which means they're all basically brand new wording. And it's talking again still about the hurricane injuries and that kind of thing. And then in addition to that, it's talking about some codes down there, W54.0, bitten by a dog, X30, exposure to excessive natural heat, X31, exposure to excessive natural cold, and X38, flood. Another guideline here about using Z codes is talking about using them to further explain the reasons for the patient presenting for healthcare services, including transfers between healthcare facilities. Again, be aware of the fact that, they're looking more and more to look at the whole patient spectrum across all sites of service, and they're finding that some of the additional cost of care and that thing are coming not in the inpatient setting, but in the post-acute care setting. So they're trying to capture a lot of those types of things and factor them into how that's affecting the total cost of care of that patient, the readmission rates, and all of that stuff. So you see on this slide all of these Z codes, including homelessness, inadequate housing, poverty, awaiting admission to adequate facilities elsewhere, unavailable or inaccessible facilities and other agencies, etc. And then that last one there, a counter for event dependence during a power failure. And there is a bullet point at the bottom there that states that this is not an all-inclusive list. There may be other codes that are applicable to those encounters based on the documentation, and to assign as many codes as necessary to fully explain each healthcare encounter. Some hospitals go into great detail with these types of codes and others do not, but just again, keep in mind as we go forward with risk adjusting that sometimes these can play a big role in sort of explaining some of the risk adjustment that we're looking at for our reimbursement. In the neoplasm chapter, we basically have the addition of upper and lower eyelid, and you can see the last bullet point there. This gives you an example of what they did to replace what we had previously and expand it out. And they basically went through all the neoplasm codes for the eyelid and made this same exact change. We also have a guideline that's been revised a little bit based on current or history of malignancy. Talking about current malignancy versus personal history of malignancy, they, in that second bullet there, they talk about that when you have a primary malignancy that's been previously excised or eradicated, and there's no further treatment directed at that site, and there's no evidence of any existing primary malignancy, and they've added the wording at that site, again, that you would code the personal history code from Z85 category. And then they've added another bullet at the bottom there, the subcategories Z85.0 to Z85.7 should only be assigned for the former site of a primary malignancy, not the site of a secondary malignancy. And that's a little bit of a clarification and change from what we've been doing previously. Codes from subcategory Z85.8 may be assigned for former sites of either a primary or secondary malignancy included. But again, those first categories there are for the former site of a primary malignancy. In the endocrine chapter, we didn't have a whole lot of changes. Again, you can see they basically respelled hyperkeratonemia, and then they added the word primary that in that E72.53 code for primary hyperoxaluria. And you can kind of look through the rest of that page in terms of how they gave us some additional specificity with the disorders of amino acid metabolism, and the hyperlipidemia has been split out as well. In the mental and behavioral chapter, this is kind of an interesting one. They've added 2 codes for cannabis dependence with withdrawal. I can't talk today, I'm sorry. And cannabis use unspecified with withdrawal. Karen and I had a conversation about this a couple of weeks ago about how do you have withdrawal when you only have cannabis use documented. And Sue Prophet spoke about this as well when she was speaking at the clinical coding meeting, that apparently they are finding that people that are using cannabis, although not dependent on it, actually do experience withdrawal symptoms. So that's kind of an interesting thing, and obviously that's the reason they've added these 2 new codes. And then they made a change here with postpartum psychosis. They deleted F53 and split it out to F53.0, which is postpartum depression, and F53.1 puerperal psychosis. Unfortunately, I'm not really sure what the main differences are between those 2, but just be aware that they are 2 new codes that are available. We also have some clarification on this psychoactive substance use unspecified, and it's added here to clarify for all of us that this guideline only relates to the unspecified diagnoses, the codes for unspecified psychoactive substance use, and it shows all of those in parentheses, and they've added F18.9 and 0.9 into that. And then they've gone on to say that these codes are only to be used when the psychoactive substance use is associated with a physical, mental, or behavioral disorder, and such a relationship is documented by the provider. When we get to the OB changes later in the webinar, I'm going to come back to this little guideline here because they have a different guideline applying to OB patients. Factitious disorder is something new, or I guess revised in terms of specificity. We had previously F68.10 Factitious Disorder Unspecified, and they have basically split that out into F16.10, 0.11, 0.12, 0.13, and they've added the terms imposed on self throughout those. Previously, all of that relates to factitious disorder imposed on self was called Munchausen syndrome. And then they've added a new code, F68.A, which is factitious disorder imposed on another, which we have also heard before, called either factitious disorder by proxy or Munchausen's by proxy. And then we have the guideline, the coding guideline that goes with these codes. Factitious disorder is basically a falsification of medical or psychological signs or symptoms or induction of injury or disease by deception. And then they describe in this first bullet of the guideline that factitious disorder imposed on the self or Munchausen syndrome is a disorder in which the person falsely reports or causes his or her own physical or psychological signs or symptoms. For patients with documented factitious disorder on self or Munchausen syndrome, the appropriate code from category F68.1 should be assigned. The Munchausen syndrome by proxy, or MSBP, is a disorder in which a caregiver or the perpetrator falsely reports or causes an illness or injury in another person or the victim under his or her care. Most of the time, obviously, this is happening to children where an adult, a parent, or a caregiver is doing something to a child, maybe a person or even a person that has a disability. And the perpetrator, not the victim, is the one that receives this diagnosis of F68.A. So make sure that you understand, I've kind of underlined in this guideline to clarify this, that F68.A is going to go on the perpetrator's record. The victim of the perpetrator, the victim of that Munchausen's by proxy, is going to be assigned a code from category T74 for an adult or child abuse, neglect, or other maltreatment, or T76. Actually, the T74 is maltreatment confirmed, and the T76 is the maltreatment suspected. So again, make sure that you have it clear in your mind which code goes on the perpetrator's record and which code goes on the victim's record. In the nervous system chapter, we have a few changes here. They have added laterality to G51.3 for clonic hemifacial spasm. And then we have some additional specificity added to muscular dystrophy codes, G71.00 unspecified, G71.01 Duchenne's or Becker's muscular dystrophy, 71.02 fascioscapulohumeral muscular dystrophy, and then G71.09 other specified muscular dystrophy. We also have a change that actually came from the IPPS final rule that I just put in here while we were talking about this. G93.40 encephalopathy unspecified and G93.49 other encephalopathy previously were counted as MCCs in the MSDRGs, but October 1 changes, they did downgrade those to CCs. And the reason that they stated in the rule that they were doing that is to promote having CDI specialists and coders try to obtain additional specificity about the type of encephalopathy that the patient has. And you can see again the last bullet shows that metabolic and toxic encephalopathy still remain as MCCs. We have a few changes for the eye and the Adnexa. Again, we talked about the code breakdown for upper and lower eyelids. for the codes and categories listed there: blepharitis, H01 codes, ectropion, H02.1 codes, logophthalmus, H02.2X, and meibomian gland. In the H04.2 codes for epiphora, they have revised lacrimal gland to right side, and then they added laterality to the H10.82 codes for rosacea conjunctivitis. And they added laterality in the codes for brow ptosis, H57.8 category. Circulatory system had some changes, some of the more frequent or important changes. One of the things that they did was a little housekeeping thing under I63.219. They changed the word arteries to artery. Not exactly sure why they did that change, but be aware of the fact that they basically made that small change. They did the same thing for I63.239, I63.333, and I64, I'm sorry, that should have been an I, not an L there, 63.343. And then in category I63.8, they did give us a code breakdown for some additional specificity. And this one, this I63.81 is for other cerebral infarction due to occlusion or stenosis of small arteries, basically lacunar infarcts. You have probably seen those on your imaging things in your records often in the past, and we haven't really had a way to really capture them. And so based on the Coordination and Maintenance Committee minutes, they talked about the fact that those cerebral infarcts of those small penetrating branch vessels in the deeper portions of the brain account for almost 1/4 of all ischemic strokes. So it's definitely something significant that we need to be able to code out separately. Those are called lacunar infarcts, and lacunae refers to the space that is left after the infarct heals. And then we have the I63.89 other cerebral infarction. And we also have I67.850 cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy, and I67.858 other hereditary cerebrovascular disease. Then we have another little change to the hypertension with heart disease guideline that rocked our world a year or two ago. They revised the categories of I51 codes that are included in this guideline, I51.4 to I51.7 and I51.89 and I51.9, and they added that same clarification in the next bullet there. And they also revised the wording there. But before I get to the wording, the one thing that I wanted to point out there is that the one code that is not included in that is the code for Takotsubo syndrome, the I51.81, which you see at the bottom of the slide there, or broken heart syndrome. There was a coding clinic that came out in second quarter 18 talking about this, in which they state that that particular condition is not included in this code range above because it is due to stress and not related to hypertensive heart disease. So basically that was removed from the code categories that are included in that I11 code range. In the middle bullet there, they do clarify the wording a little bit. Previously, the guideline had stated that they would be coded separately if the provider specified a different cause other than hypertension for the heart condition. They've backed that up a little bit and softened it, as Nellie Leon Chazane said. Now it only says the provider has documented that they are unrelated to the hypertension. So it's not stating that the provider has to state an additional cause. It just has to say that he has to document that whatever the heart condition is not related to the hypertension in order to code those out separately rather than coding them to the I11 category. They did the same thing here with the hypertensive chronic kidney disease, again, backing that up a little bit to state that if the provider indicates that the CKD is not related to the hypertension, then you would code them out separately. And then in pulmonary hypertension, the guideline there, they added some additional wording there that the sequencing is based on the reason for the encounter, except for adverse effects of drugs when you're talking about coding pulmonary hypertension in category I-27. They also have a guideline that basically states what they came out with in fourth quarter 17 coding clinic, where they talked about the different types of MIs, and they talked in there about how to use that category I-22. So they've added that now into the guidelines. Just a reminder to you that we have I-21 and then we have category I-22 if they have a subsequent MI within 4 weeks of the first MI. And basically what they have said there is that only applies to type 1 MIs. So if they have a subsequent MI of one type that occurs within 4 weeks of an MI of a different type, you would assign the appropriate category from I-21 to identify each type. You would not assign a code from I-22 subsequent MIs if anything other than type 2 is involved. I mean, sorry, if anything other than type 1 is involved. The I-22 only applies to type 1 MIs, whether it's the first MI or the subsequent MI. If it's a type 1 and then they have another type later, then you are going to code it to whatever that type code is rather than the I-22. Hopefully I clarified my misspeaking there. Then they also added and I-21.9 into the guideline. When they added those additional types of MIs, the type 2, 3, 4A, B, C, and 5, that changed what the default MI code used to be. It used to be an I-21.3, which I think was a STEMI unspecified, but now that we have all the different types, I-21.9 MI unspecified is the new default code, so they have added that into the guidelines there. Very small little change on the respiratory system, and this really again came from the IPPS rule that acute respiratory distress syndrome has been upgraded from a CC to an MCC effective October 1. Some pretty major changes with the digestive system related to acute appendicitis codes. And as you look through these slides and the additional specificity there, you can see a lot of different components that you have to pay attention to. Peritonitis, whether it's generalized or localized, is one of the issues that you have to look for. And then you have to look for whether there's perforation involved or whether there's abscess involved. All of those different variables are needed to pay close attention to your documentation to see how to assign these codes correctly. And you can see I have out beside the codes which ones of those are CCs and MCCs. If it's generalized peritonitis without an abscess, it's going to be a CC. If it's generalized with an abscess, it's going to be an MCC. And then when you get into the localized peritonitis codes, the K35.3 codes, without perforation or gangrene is a CC. If you have gangrene but no perforation, that's still a CC. If you have perforation with no abscess, it's an MCC. If you have perforation and localized peritonitis and an abscess, it's an MCC. So pay close attention to those variables and to which ones are CCs and MCCs as you go forward. And then the last slide there are the ones that have pulled in the gangrene. Basically, as I said, one of the things that's really significant about all of this is whether it's generalized or localized peritonitis and whether there's perforation and whether there's an abscess. Again, moving forward, talking about some of the information in the Coordinates and Maintenance Committee minutes, they talked about the progression that occurs starting with inflammation, progressing to gangrene, then to perforation, then to abscess or generalized peritonitis. So whether there's perforation or not is one of the most important distinctions, because perforation basically means that you've got bacterial contamination that's spilled into the peritoneal space, and that obviously has serious implications for you know, how seriously ill that patient is going to be and how easy it's going to be to get them well and get that bacterial contamination contained. No perforation basically means that there is no bacterial contamination that's spilled into the peritoneal space. However, the word peritonitis can be misleading based on how physicians use that. It may or may not be talking about generalized peritonitis. It could just be talking, a doctor could say peritonitis just talking about the fact that the peritoneum, there's just sterile inflammation of the peritoneum, but there's not actually bacterial contamination in there. So be aware of looking for some evidence in your record about whether there's bacterial contamination or not. Also note that localized peritonitis is coded to that K35.3 code. One final thing at the bottom of this slide is K57 diverticular disease has a code also note for peritonitis. The C&M minutes talked about the fact that diverticulitis with perforation codes could be improved by distinguishing whether or not generalized peritonitis has occurred. That's something that we're going to have to be looking for in the documentation. If we have diverticulitis and there's some evidence of perforation, do you have evidence of peritonitis or bacterial contamination or not? Because if you add that additional code, I think we used to get an MCC for this without the additional code, but now I think going forward with October 1, you have to add that additional code in order to be able to get an MCC. In talking about this last abscess category here, K61.3, they deleted that and expanded it, and now we have K61.31 for a horseshoe abscess and K61.39 for other ischiorectal abscess. A horseshoe abscess basically spreads partially circumferentially around the anus or the rectum, and it's shaped like a horseshoe, hence the name horseshoe abscess. So that would be the types of documentation that you would be looking for to assign that 61.31 code. The default code would be the K61.39. And then we have an additional code at the bottom there, K61.5, for supralevator abscess. Also, we have a couple of more changes in the digestive system. We have a code K82.A1 for gangrene of the gallbladder and cholecystitis, and a code first note has also been added there to code the cholecystitis. And then we have K82.A2 for perforation of the gallbladder and cholecystitis. Again, code also notes under cholecystitis and cholelithiasis codes to remind you to code the gangrene of the gallbladder code, since it's a new code. And then we have a further subdivision for cholangitis. It's been broken down into K83.01 for primary sclerosing cholangitis, and then the other cholangitis. Sclerosing basically means that there's pathological hardening of the tissue, especially from either overgrowth of fibrous tissue or interstitial disease. And even though that primary sclerosing cholangitis is a very rare condition, it's the most rare of the autoimmune liver disease conditions, they are finding more and more that there's no way to slow down the progression of that disease or to cure it except for doing a liver transplant. And they are finding that more and more patients at much younger ages are undergoing liver transplants because of that primary sclerosing cholangitis. So they felt the need to split that out with its own code so that they could capture how often that is occurring. In the integumentary system, we have some clarification here. The L98.495 non-pressure chronic ulcer of other sites, they've added ulcer of skin of other sites with that, and the same thing for the L98.496 and L98.498 categories. In the musculoskeletal system, the myalgia code has been split out into the different muscles that are involved in the myalgia. So I'm not sure exactly who was interested in classifying that information, but we do have more specificity in that code category. In the genitourinary system, they are trying to make a distinction here when you're talking about urethral stricture of the male of overlapping sites. They are distinguishing between post-traumatic, post-infective, and post-procedural. And so be aware of that. And then you can see for that N35.8 category, they have added a lot of site specificity for the other urethral stricture. And then at the very bottom there, they have a code category N35.82 for other urethral stricture of the female. They went through the same exact breakdown revision for code category N35.9 unspecified urethral stricture as well. In the OB code, this revision right here was just to correct an error that they had previously. O00.212, left ovarian pregnancy without intrauterine pregnancy, should read with intrauterine pregnancy. Then we have some new codes for multiple pregnancies. The O30.131 has been split out by trimester, and they did the exact same type of breakdown for O30.231 for quadruplet pregnancy, again by trimester, and then the same code breakdown for O30.831, other specified multiple gestation, again the codes based on trimester. And the codes for the 6-digit unspecified trimester are not going to be counted as CCs like the others are. So in a hospital record, you really should not have to assign that unspecified trimester. But I have actually seen that recently in an audit that I did. There were other documentation pieces in the record that would lead the coder to understand what trimester the patient came in and delivered, but because it wasn't spelled out in black and white exactly, the coder did assign that unspecified trimester. So because that is not a CC, that's something that you want to avoid and try to make sure that you are able to specify the trimester whenever possible. They also have done for both OB infections and regular infections a breakdown of surgical wounds. These codes, 086.0, infection of obstetric surgical wound, has been further broken down. We have an unspecified code there, 0.00, and then 0.01 is superficial incisional site. 0.02 is for deep incisional site. 0.3 is organ and space site. And then we also have this additional 086.04 sepsis following an OB procedure. That particular code is an MCC. Unfortunately, I don't think any of those other codes are a CC or an MCC. And going back to those definitions for superficial, deep incisional, and organ and space, I'm going to define those when I get to the other set of infection code changes. So I will get back to that and help you understand the differences between those definitions. We also have a guideline. Remember, I talked at the very beginning about the guideline about unspecified codes for psychoactive substance use, and basically we were told in that guideline that you aren't going to code use of those drugs unless it's linked to a documented problem or diagnosis. However, for pregnant patients, the guideline is basically telling you that they want you to code drug use. Category 099.32, drug use complicating pregnancy, childbirth, and the puerperum, should be assigned for any pregnancy case when a mother uses drugs during the pregnancy or postpartum. This can be illegal drugs, inappropriate use or abuse of prescription drugs, etc. And then it has a reminder that secondary codes from categories F11 through F16 and F18 through F19 should also be assigned to identify the manifestations of that drug use. So do be aware of the fact that the guideline for assigning drug use is different for pregnancy patients than it is for others. We also have some additional specificity here for this P02.7 category for newborns affected by chorioamnionitis. And then we have a huge expansion of the P04 codes here, newborns affected by maternal condition. Again, remember that this category is only used when the listed condition in that code has been specified as the cause of either confirmed or potential morbidity in the newborn. That is when you would assign these codes. And you can see that the breakdown here shows all kinds of different drugs that the mother might use that would affect the newborn. They also continue on with the expansion here on this page with the codes for the use of cannabis. And again, that note, as I said, about when they are supposed to be used is listed there at the bottom of that slide. We also have some additional P codes. We have a new code for congenital Zika virus disease, P35.4. And then we have some additional specificity for sodium balance, hyper and hyponatremia of the newborn, hyper and hypokalemia of the newborn, and then other electrolyte disturbances, including alkalosis, hyperchloremia, and hypochloremia, and then other transitory electrolyte disturbances of the newborn. And then we have in congenital conditions category, they've added some additional clarification there, or specificity, to differentiate between complete and partial doubling of the uterus or other specified doubling of the uterus. And then that deletions of a part of a chromosome code has been split out into additional specificity for Angelman syndrome, other deletions of a part of a chromosome, and Williams syndrome. In the signs and symptoms chapter for the Coma scale, they made some revisions there that R40.2330, that abnormal, they've added the words abnormal flexion into that code category. And they did the same thing for motor response codes in those additional categories that I have in that second bullet there. And they also added into the alpha index under the word coma with motor response, the breakdown of the scores 1 through 6 and the corresponding code, so that you can actually see the codes in the alpha index rather than having to go into the tabular list. Then the guidelines that kind of correspond with that, they basically just added that additional sentence at the bottom that you do not report codes for individual or total Glasgow Coma Scale scores for a patient with a medically induced coma or a sedated patient. Obviously, you know, that doesn't have the same meaning as being in a coma because of a physical condition. One of the things that I wanted to say about the Glasgow Coma Scale scores before I leave that is those codes are severely underreported today, and those codes can impact severity adjustment. They can also provide clinical support when you have an altered mental status diagnosis or an encephalopathy diagnosis or even a sepsis diagnosis. The Glasgow Coma Scale scores are one of the things that is listed on the SOFA table. So those are things that y'all need to be paying attention to. And if they have a coma score that's less than 15, which is normal, you may want to take a look at, based on what's wrong with that patient, you know, reporting those scores, because as I said, in some cases it can actually add an MCC and give you a higher DRG reimbursement, but at the very least it can provide clinical justification and or risk adjustment for you. We have some additional codes in the abnormal findings category. R82.99 has been split out, and I'm not going to try to pronounce all those words there, but you can see that they're all related to abnormal findings in the urine. And then some codes on diagnostic imaging. Again, we have some additional specificity added, right and left testicle, bilateral testicle, etc. In the Chapter 19 code for injuries, there were a whole lot of code changes in this category on the fracture codes, but the changes were pretty minimal. You can see that F62.626A displaced fracture of the medial phalanx of the right little finger. They revised that word medial to middle, and they did that exact same change for all the fracture of the finger codes for all the 7th characters throughout the classification. And then they made spacing corrections for all the physio fracture codes throughout the classification and all the Salter-Harris fracture codes. So as you can see, a lot of codes were changed, but the changes themselves were fairly minor. In the burn guideline, they added some clarification here. The second guideline there is entitled Burns of the Same Anatomic Site. Classify burns of the same anatomic site, and they added and on the same side that are different degrees to the subcategory identifying the highest degree recorded in the diagnosis. the example there, 2nd and 3rd degree burns of the right thigh. So both the same side and the same side have been added for clarification. And then they also added an additional sentence to the assigned separate codes for each burn site. Codes for burns of multiple sites should only be assigned when the medical record documentation does not specify the individual sites. And hopefully in an inpatient setting that would not be the case. You would be able to code out each separate burn individually. Underdosing, they also made some additional wording changes or additions to this code, or guideline rather. Underdosing, as you know, refers to taking less of a medication than is prescribed by a provider or a manufacturer's instructions. And this is something that we've had to get used to in ICD-10. It's not something that we thought of before, and we are supposed to pay attention also to when the underdosing either causes an additional physical condition or exacerbates a chronic condition because they're not taking their medication, and we have guidelines about how to code that. The wording they've added here in the guideline is to say that discontinuing the use of a prescribed medication on the patient's own initiative, not directed by the patient's provider, is also classified as an underdosing situation. And then they go on down at the bottom that slide for non-compliance, and they've added Z91.14 to that. And the point here is that both non-compliance and underdosing really should be coded together in these particular situations. And I think some cases the coders are doing a better job of picking up the non-compliance code, but not picking up the underdosing code. And if you will remember, the non-compliance codes are somewhat generic. You can capture, some specificity about what they decided to do or not do, but the underdosing codes actually give you the actual drug that they quit taking. So it's important to capture both of those together whenever you have that documented in your medical record. Also, we have a whole lot of additional poisoning codes here for poisoning by ecstasy with all the 7th characters, etc. And the only point that I want to make here, just to point out to you that instead of being classified as a hallucinogenic drug, ecstasy was classified as an amphetamine derivative. We have some codes here for exploitation. T74.51 is adult forced sexual exploitation confirmed, and 0.52 is child sexual exploitation confirmed. And then we have the next set of codes for adult and child forced labor exploitation confirmed. Then we have new codes for adult forced sexual exploitation suspected and forced labor exploitation suspected. Again, a guideline to go with those codes: if a suspected case of forced sexual exploitation or forced labor exploitation is ruled out during an encounter, code Z04.81, encounter for examination and observation of the victim following that forced sexual exploitation, or Z04.82, encounter for examination and observation of a victim following forced labor exploitation, should be used rather than a code from T76. Now to the infections following a procedure that I talked about before. You see the same breakdown that we had in the OB codes of superficial, incisional site, deep, and organ and space, and the additional code for sepsis following a procedure. And these definitions here came from the CDC. They have a health safety network, National Health Safety Network, that they hired to abstract data for this, and they developed these definitions. Superficial incisional site means that it only involves the skin and subcutaneous tissue of the incision, such as a stitch abscess. Deep means that it involves deep soft tissues of the incision, including the fascia, muscle, and intramuscular layers. And then organ and space involves any deeper part other than the fascial muscle layers that is opened or manipulated during the procedure, such as an intra-abdominal abscess or a subphrenic abscess. A subphrenic abscess is where you have accumulation of infected fluid between the diaphragm, the liver, and the spleen. And one of the things that was pointed out in one of the presentations that I heard is they are stating in these definitions from the CDC and the National Health Safety Network that these definitions for superficial incisional site do not include cellulitis by itself. Cellulitis is characterized by redness or warmth or swelling at the site, incisional site, whereas infection is indicated by purulent drainage at the incisional site or a positive culture. So they are really recommending that you make a distinction and look for the definition of infection to see if there's evidence of actual infection as opposed to just cellulitis at that incisional site before assigning these codes. And it's recommended that you develop a coding policy in your facility to clarify how you're going to do this. If you have only cellulitis documented at the incision site and there's no evidence of infection, the purulent drainage or a positive culture, are you just going to code that to cellulitis and let that go, which is what they recommend at the CDC, or are you going to query for clarification or whatever? But it's important that the coders understand the difference between only cellulitis being documented at that site versus signs and symptoms of infection, and making sure that everybody knows exactly how to code that going forward. Then we have a lot of guidelines related to sepsis during a post-procedural infection. And it talks about here for infections following a procedure, a code from T81.40 to T81.43, or a code from the pregnancy codes 086.00 to 0.03 that identifies the site of the infection should be coded first, if known. And then you would assign the additional code for sepsis following a procedure, which is the T81.44, or if it's an OB procedure, 086.04. So basically the coding there would be, you would have both T81.42 for infection involving the deep incisional surgical site, plus the T81.44 sepsis following the procedure. Both of the codes are needed because the T81.42 captures the depth of that surgical site infection. Then you need an additional code to identify the infectious agent if documented, and hopefully it would be. And it goes on to state that if the patient has severe sepsis, the appropriate code from that R65.2 should also be assigned along with the additional codes for any acute organ dysfunction. So you see the coding there would be the T81.42 for a deep incisional site, the T81.44 for the sepsis, the R65.20 for severe sepsis, and then N17.9 for the organ dysfunction of AKA, and then a code B95.2 to show the organism involved. Then they add this whole new wording into the guideline that says for injections following infusion, transfusion, therapeutic injection, or immunization, a code from this category T80.2 or T88.0, infection following immunization, etc., should be coded first, followed by the code for the specific infection. If the patient has severe sepsis, the appropriate code from subcategory R65.2 should also be assigned with the additional codes for any acute organ dysfunction. However, then they go on to talk about in this guideline that if you have post-procedural infection that has developed into post-procedural septic shock, you're going to assign the code for the sepsis due to a post-procedural infection. And then instead of the R65.21 severe sepsis with septic shock code, you're going to add that T81.12 code post-procedural septic shock. So again, you see down here how that would be coded for septic shock of post-procedural sepsis, T81.42, T81.44, and then the T81.12 for the post-procedural septic shock, the AKI, the N17.9, and the cause of infection. We have one additional code in this external cause codes here, multiple perpetrators of maltreatment and neglect to mention. We have some additional specificity in this Z04.81 category that I won't read to you, but you can see it there. We have a bunch of screening codes that have been added here. The Z13.3 category and Z13.4 categories have been expanded, and you can again see what those are showing. And then we have some additional Z codes on this slide, and I just wanted to point out that second one there, Z28.83, immunization not carried out due to unavailability of vaccine. I believe that giving the vaccines, pneumonia and maybe flu, are part of one of the quality measure indicators. So it's important that if they are not able to give an immunization because there's no available vaccine, that might be an important code category to add. And then the final thing is this additional wording in the BMI guideline that BMI codes should only be assigned when the associated diagnosis, such as overweight or obesity, meets the definition of a reportable diagnosis. Do not assign BMI codes during pregnancy. Again, there's been a lot of controversy and discussion about how, BMI, how pregnancy affects BMI, and it's probably not a real good measure of that patient's BMI if they're pregnant. So they have basically decided not to have us assign a BMI code on a pregnant patient. And that pretty well covers everything that I wanted to talk about today. So I'll turn it back over to Karen and/or Sharon.
Well, hey, Joy, this is Karen. We do have a couple of questions. I know we don't have a whole lot of time, but there was some questions about the history of malignancy codes, and I know that becomes kind of confusing. So can you just talk about that? The question actually says, if a patient has breast cancer and has had a double mastectomy and is receiving chemo for breast cancer, is that history of since she already had her bilateral mastectomy?
You broke up a little bit there, but I think you said, does that meet the guideline for primary malignancy and that guideline that is there? Is that what you were saying?
They were asking about the history guideline, the history of the malignancy codes. If you could just clarify that a little bit more. Okay.
Basically what they did here, they basically say, when a primary malignancy has been excised and further treatment or additional surgery, including radiation, chemo, is directed at that site, the primary malignancy code should continue to be used until treatment is completed, which has always been the case. When the primary malignancy has been previously excised or eradicated, and there is no further treatment going on, no chemotherapy or radiation or anything else, and there's no evidence of any existing primary malignancy at that site, then you're going to code that Z85 personal history of malignant neoplasm to indicate the former site of that malignancy. And they went on to clarify that Z85.0 through 0.7 category should only be assigned when the former site that you're talking about was a primary malignancy, not a secondary malignancy. So if in your example, breast cancer is, was the primary site, if they have completed all the surgery and chemo, radiation, post-surgery treatment, and there's nothing else going on, then that would apply in that case, that you would assign that Z85.0 to 0.7 for the breast because it was a primary malignancy. If you have evidence of a former site that is either a primary or a secondary malignancy, that subcategory Z85.8 is available, but the 0.0, 0.7 parts of that Z85 category should only be assigned when it is a primary malignancy that has been completely eradicated and they have a history of that primary malignancy basically cured. Hopefully that helped.
I think it did. Thanks very much. I think we have time for, actually, we've just got 1 minute left, and I know that Sharon needs to talk to everyone about getting your CEs. So let's go ahead and turn it over to Sharon. Thanks, Joy. Sharon?
Thanks, Karen. So I just want to remind everybody that tomorrow morning you'll be receiving an email from us. It will contain a link to a survey. When you click on that survey, it's very brief, just asks you about your feedback on this webinar. When you submit it, you'll be able to download your CEU certificate, or you can also go directly to this link that's in the slide that Joy's showing. That's another way to get to your CEU credit. Also, that email will contain a link to the recording of the webinar, so you can view it on demand, and it'll have a link to the handouts as well. And we will go through the remaining questions, and If Joy doesn't mind, she can respond to them by email and we'll follow up with you to make sure your questions do get answered. So thanks everyone for attending, and thank you Joy and Karen for your help in presenting this webinar.
Thank you. Goodbye, everybody.
Thanks everyone.